Welcome back to our final session of the Population Health Management virtual program. We are very excited for this session, which is a panel discussion delivering behavioral healthcare in a virtual environment. Many thanks to our partners at NeuroFlow for their support of this session. With that said, I would love to once again bring on and welcome our editor-in-chief here at Healthcare Innovation, Mark Haglund, who will be the moderator for this final session. Mark?
Thank you so much, Matt. And thank you to everyone in our audience. We really appreciate your continued participation. It's my pleasure and honor to welcome Rebecca Phillips, Division Vice President of Clinical Operations at Kindred Behavioral Health, Dan Olshansky, Vice President of Quality at Behavioral Health Network, and Matthew McClett, Head of Clinical Operations at NeuroFlow. Rebecca, Dan, Matt, welcome to you all. Thank you for joining us. I think before we even go into the substance of our session, I'm just going to have each of you share yourself, share your identity with our audience, talk a little bit about your role, and a little bit about your organization, because in all three cases, I think we'd like to understand your organization's relationship to our topic. So I'm going to do ladies first. Rebecca, I'm going to ask you, go ahead, please introduce yourself and your role. And also, as you and I had discussed, the behavioral health division at Kindred is a kind of a new division. So perhaps you can context that for us.
Yes, I'd be happy to. And thank you, Mark, and welcome to all of our audience participants. My name is Rebecca Phillips. I'm the Divisional Vice President of Clinical Operations for Kindred Behavioral Health. And for those of you who may not be aware, Kindred has a relatively new behavioral health division. We formed 2 years ago as a division of Kindred Healthcare. Kindred Healthcare, in addition to behavioral health, of course, does rehab services and long-term acute care. So I was really honored to become a part of this new division as the Chief Clinical Officer and VP of Clinical Operations. And under that auspice, I have the honor and good fortune to work with our clinicians out in the field, both nursing and our non-nursing clinicians. I'm a licensed marriage and family therapist by licensure, an art therapist by background, and very excited about the opportunities to use technology and innovation in serving our patients in our various locations. So again, thank you for allowing me to be part of this panel this afternoon.
Thanks so much for joining us, Rebecca. Welcome. Dan, why don't you go next and introduce yourself and your organization?
Thank you. I'm Dan Olshansky. I am the Vice President of Quality at the Behavioral Health Network in Western Massachusetts. We are a large behavioral health organization of serving about 35,000 individuals a year. We have a range of services, including residential care for individuals with mental health and substance use disorders, and also developmental delays. We have a large outpatient department that serves about 19,000 individuals a year. We have crisis programs for Hampden County, which is a southern county in southwest Massachusetts. We also have 2 detoxes. We have programs for specific populations, such as for kids, for individuals who've experienced domestic violence or partner violence. We have some daycare centers and a increasing set of programs geared towards care management for individuals with behavioral, but also many with medical comorbidity. The agency has been around a long time and has experienced a lot of growth, and that part of the reason talking today is looking to become more adept at meeting the needs of our population, which tends to be a more disenfranchised group and is quite disparate in terms of availability of the internet and broadband, and also many live in rural areas where access to care is a challenge.
Thank you so much, Dan. Matt, please go ahead and introduce yourself.
Everybody,
you're muted, yeah.
I got it. We're in past COVID land now, right? So hey, everybody, Matt McClett, my team refers to me as Mick. So it's a pleasure to meet you all. I am the head of clinical operations at NeuroFlow, which is a great job. I'll get into more as we go on. My background is actually military medicine. So I did combat trauma for a number of years and then moved into doing inpatient psych. I got to lead inpatient psych units, which is to this day my favorite job, but don't tell my boss that. Also got to work a lot in substance use, mental health policy. But always what my driver has been, the passion that I've always had, is impact at scale, right? So how do we take all of these lessons learned, the research, my wife's a researcher, she does all this great work. How do we do the great stuff she generates and actually make it tangible and happen? I've always thought of myself as kind of the mover and shaker, right? So what does that mean and what brought me to NeuroFlow? Well, there are a lot of integrated care models that are evidence-based for over 20 years, right? We're talking 80 random controlled trials for things like psychiatric collaborative care. But when we look at the number of health systems that are adopting these models, it is minuscule. So what we're allowing to do and what we're doing is using technology to allow these integrated care models to be brought in settings where traditionally it has been incredibly challenging to bring mental health, primary care, obstetrics, population health organizations. And who we actually end up working with is certainly health systems and health payers, but we also have several government contracts. So we're live across more than 15 military installations today. So working really in a whole bunch of different settings to really bring mental health to areas where it's desperately needed and has not been available in the past. So looking forward to digging in with you guys, but it's a pleasure to be here.
Would you prefer to be addressed as Mick rather than Matt? It's up to you.
Matt is fine for now.
Okay, all right. I always try to address people the way they wish to be. Well, thank you all. Really appreciate your introductions. Let me just do a tiny level set, and really, this is going to be a couple sentences, but as we all know, one of the things that has happened during this pandemic is it's shifted everything around in terms of access and in terms of modality, right? And so much has gone remote, initially out of necessity, and we'll be talking about this, also moving forward by choice of patients and clients and sometimes providers. So it's a complex landscape because everyone's trying to figure everything out. And at the same time that the pandemic hit, we were already trying to figure out how to more optimally deliver behavioral care, right? And so it's like several cross-hatching each other at once. So complex landscape. Let me ask you, let's begin by talking about the context of the pandemic. Let me start with Dan and Rebecca and go to Matt. What have been some of the things that have happened to your organizations simply delivering care during the pandemic, and how have you been able to adjust to shifting situations on the ground? Dan, why don't we begin with you?
Sure, thank you. So because we do residential work, work out in the community, which is in people's homes or schools, and then in the clinic, each of them had different challenges. For the residential programs, we still have people needing to be detoxed, still have literally hundreds of beds of individuals getting services. And so the need to figure out ways to provide care to keep both the clients and the staff safe with PPEs and all sorts of precautions, and then deal with the fact that people would come in with COVID and then having to medically manage them within the setting. So that posed a huge set of challenges in terms of still trying to serve people with the usual constraints that occur for individuals and their own reticence to get care within that context. So that was one of the big challenges. When it came for the outreach, many people were reticent to have people go out to their homes. And so we would have staff go out literally covered with the PPE, including the face masks and the shields and all the rest. And some people, of course, didn't want that to happen. So for programs where it really didn't fit, like our early intervention programs, those programs were significantly cut back in terms of their ability to provide the kinds of hands-on services that are really needed for young kids, which is early intervention. And then the programs that involve the more traditional counseling, therapy, care management, we did find that that could happen much more by telephonic or video conferencing than we had ever anticipated. Certainly that's been an option on the psychiatric realm for a number of years, but there was always a reticence to go in that direction because, and I'm a social worker, as was mentioned, because of our sense of, oh, it's the relationship that's interpersonal that's so important. And it is. But many people do find it still either sufficient or even sometimes better. And for individuals with issues around accessibility, mobility, or a life that is really chaotic, especially with kids staying at home now because of COVID, you know, the ability to actually get out to a clinic for themselves or their family was really a non-starter. So we very quickly mobilized towards using Zoom as our video conferencing platform because it could be HIPAA compliant, and then which is really just about business association agreement. The technology has always been sufficient to support that. Anyway, so it's been the challenge of getting people acclimated to this, but necessity was the mother of invention, and people were willing to jump in really weeks. We got everyone on board using it. And in some areas, there was actually better access for certain individuals where certain, in part because of COVID and people not going out, they were much more available. And we had some upticks in the ability of show rates and things like that for many services. So the big piece was looking at different levels of care. How do we make adaptations or even have to cut back programs because we just couldn't keep people safe in terms of the necessary space. And so in certain kinds of programs where there were shared rooms, those would become singles. And so our general capacity would go down. And what, so before we get to maybe solutions, so that was the effect about how it hit the system, our system of care. And then perhaps later we'll get into the, how did we respond to all of that?
Yeah, absolutely we will, for sure. Thank you, Dan. Rebecca, I have a very specific question. Was your division created just before the pandemic hit? Can you share about the timing and then what you did?
Yeah, so the division was born, if you will, or created in June of 2019. So just really getting ramped up. I came on board at the end of October, third week of October of 2019. And at that time, so we were really just getting started. We were, had management in one of our long-term acute care hospitals underway already. And then as we moved into 2020, just in May, June of 2020, right in the, kind of the throes of acute COVID, I call it acute COVID year or whatever, we were bringing up, new management service agreements. And shortly after that, we acquired 2 freestanding hospitals in Texas. So all throughout the pandemic, we were and are still very much in growth mode. So that early phase from October and moving then into 2020, we, the first way that I think our business was affected by the pandemic, was in a behavioral health program housed within a long-term acute care hospital. So you have the challenges of the very medically complex patients on the other side of the door. And then, the behavioral health program, adult services, general adult unit. And the types of challenges that we ran into initially were around really provider availability. For example, one of the psychiatric providers had been exposed to COVID in another setting where he worked. Thankfully, he didn't get COVID, but we had to quickly shift to the use of digital means to do the daily psychiatric rounds, treatment team meetings, and so on, around, just around similarly to Dan, only Dan on a larger scale, just adjusting very quickly to these changing sets of circumstances that the pandemic brought us.
Yeah, absolutely. And Matt, I'm sure you have a nationwide view. The organizations that you work with, how did everybody respond?
Yeah, it's a great question. I think when I say telehealth and when I think about telehealth, I think the majority of people right away tend to think about synchronous communication, right? They're thinking about the video, they're thinking about the chat, right? But when we're talking about this telehealth revolution, we're talking about a heck of a lot more, right? So I know it's a little easier to contextualize, like how do you replace an in-house visit with a telehealth visit, right? It's really easy to think about what that looks like. But really what I want to talk about, and we're going to, I hope, expand on today, is like, what are the capabilities that we never had before that we now have available to us through telehealth, right? And, a few examples here are remote patient monitoring, RPM, right? There's new codes that every psychologist in here should be writing down, if you don't know this already, called remote therapeutic monitoring, RTM. These are things that psychologists can be able to bill for, actually tracking outcomes and things like that in 2022. Right, we're talking about being able to do things like remote psychiatric collaborative care. I'm speaking with organizations that are rural, they have nobody available in the providers in the rural section, or I'm going to the Bay Area and talking with people where a psychiatrist costs $2,000 a year, right? Or sorry, $2 million. That's like so outside of my own mind to even consider that. So being able to really bring these delivery models and new systems of care that have never been done before to health systems is incredibly powerful. And then tying it all together too is then how do we actually get this data, and not just more data, but actually actionable data in front of the providers so that they can use it. So, the way we can use integrations and actually feed in information to where they should go, where a provider expects it to be able to action off of it, right? And all of that can be done without that provider ever, or that patient ever in the waiting room. And that's why our biggest challenge over the past 2 years has been that we've grown over 4 times, right? Our staff, our clients, we've scaled tremendously over the last couple of years. And being able to do that means we've had to be able to really meet customers' needs around integrations and making sure that data flows where it needs to. And what we do and where we uniquely kind of sit is to help health systems and payers to integrate care. And we touched on how there's so many RCTs and things out here to show that this is effective. But through technology, we can really start to streamline these workflows, right? We can fill up registries quickly, so you're not losing money in the first few months of the programs that you're rolling out. We can use digital health curriculums to really reinforce the activities that care managers are doing, and having a registry where you can track these outcomes really effectively for the first time. So that's really where we've been able to get a lot of traction, because we know there's a lot of cost savings and opportunities here that we can dive into. But largely, it's been great for us. It's obviously the pandemic's terrible, so I don't want to make it sound like it's been good for us. But certainly it's been good for this telehealth lore largely now, because it really kicked us in the butt to get moving, right? And see the value of where we can really support.
Thanks, Matt. You already started to answer my next question. So
that's great. I'm right ahead of you.
Yeah, I know. I'm going to back us up just a little bit, and then you can say what you just said again. But what, as we move forward in remotely delivering behavioral care services, what key things did we learn we're still in it, but as we move forward through the pandemic? It feels like there were a lot of learnings in the moment. How about Rebecca, then Dan, and then back to Matt?
I think we learned that we could deliver care technologically in ways that we had not entertained before. And even delivering care, with to Matt's point about remote patient monitoring, not so much remote, and maybe this doesn't fit there exactly, but to have a psychiatrist who can't come into the hospital to do rounding, and the patients who are on the unit that need to be seen by the psychiatrist or the nurse practitioner and the treatment team, right? And the overcoming the objection that everyone has to be in the same room of the treatment team to be able to have an effective dialogue around what the patient's needs are and what the treatment plan will be. I think that we overcame those objections to utilizing virtual technology and seeing it as a viable way to interact as professionals together and as a way to deliver effective care to someone.
Yes, absolutely. I think there were so many concerns. Dan, why don't you address that? I'm sure you've had many interesting experiences in that regard.
So everything that Rebecca said is really true. I think some of the injunctions had to do with providers, but also payers in the state as well. It took them and even the feds a little longer to sanction the use of telehealth. And even then, there was reticence, and I think it's still being worked out in Massachusetts, but I think it's a moot point for the feds about the use of telephonic. So for many individuals who don't have data plans and don't have iPhones or computers, a phone really is the only option. And because of the pandemic, there was a waiver that was instituted by our governor to say, yes, we are willing to reimburse for telephonic. So I think part of both the challenge and the opportunity was suddenly to be able to reach people who couldn't be reached before. And that goes back to my earlier comments of certain people who were seen as resistant or not accessing services suddenly were because they could. And that the opportunities were there and the flexibility was there on both on the provider side and the client or patient side. I think
go ahead. Oh no, go ahead, please continue.
And I think some of the other hurdles had to do with how do we get people to sign forms? What do we do about that? And because unfortunately our agency is still very much tied to paper and have not converted to some kind of DocuSign model in order to sign all the documents and also provide the informed consent. We're supposed to explain what people are signing before they sign. So we came up with and were allowed to have waivers around attestations of talking to someone, reviewing it, and being able to document that someone had the conversation and reviewed what the consents were, and then coming up with ways that were not dependent on paper forms being sent back and forth, because it was hard enough in a paper world where the clients came in, and in a virtual world, much more difficult. And that kind of gets into a later part of the conversation about where do we go from here and how to better integrate technology into the telehealth platform. But so the issues had to do with documentation, explaining things, as Rebecca already aptly said, the engagement and the acculturation of this by providers, and realizing that people could work collaboratively through Zoom like this and by using chat and other forms of communication. And then I think for the clients, there was, we did some surveys early on and in collaboration with our trade organization, ABH, looked at how are these services received by clients and what's the benefit, what do they see as the hindrance, et cetera. And generally, we had really positive results around how people experienced the service, how they really felt like they could still connect to their therapist or their care manager or their psychiatrist. So I think that was really helpful, seeing that and being able to provide that information through our trade group to the legislature and to the different state agencies.
Okay, you're triggering a thought. I want to take a slight turn here, ask you and Rebecca and Matt, how have clinicians reacted? They obviously are living in the world too. They knew what was going on with COVID, obviously, but I'm sure for some it was a difficult transition, but how have the clinicians in your organization reacted? Have they adjusted, basically?
Rebecca, do you want to go first and I can follow?
Sure, I'm happy to. The clinicians within our organizations, the facilities and the units that we manage have by and large been very open. Not so much resistant. The only, and it really isn't resistance per se, but the only challenges to Dan's point was early on figuring out just the logistics of moving consents or being on paper charts and then needing documentation from physicians and setting up, whether it's DocuSign or Adobe sign systems, putting those in place, and clinicians learning to navigate that. But I mean, by and large, within our organization, the clinicians have been very willing to get on board and learn new technologies because, clinicians at heart want to serve people. And so this was the way we could do it. And so that was our experience.
Good. Dan?
I agree with everything Rebecca said. I think now, with returning to some kind of post-COVID world where there are still risks, but a hybrid approach is indicated, we have our own internal ideas of when is in-person appropriate and when is a telehealth model appropriate or inappropriate. And then also waiting for insurance companies to come up with their own criteria and having to manage both sets of ideals about how that works. So I think the part for the clinicians is wanting to serve clients and having the option, but also wary of another layer of filtering or complexity by payers saying, well, here's the situation, here's how you documented why this was necessary and a face-to-face was not. And I think that that is still evolving, because as much as I think insurance companies appreciated the level of service, they also paid much more for these level of services that we had higher show rates. And that means more cost. And I think that's always a mixed blessing for total cost of care for payers.
Yeah, absolutely. Matt, I know you have a nationwide perspective on this. What are you seeing and hearing? Clinicians, have they been adjusting pretty quickly, or what are you seeing on a nationwide level?
Yeah, I mean, it's a great question. We work primarily with primary care providers, physical health providers, right? Busy, not that mental health folks aren't, but just incredibly busy folks. And so there's a few things that we have to do every time we work with these things, with these folks. First is figure out what their workflows look like today, right? So if you're not fitting into existing workflows, it's not going to work, right? It's going to fall apart. The other thing is we know that more data, I think I touched on this, more data is not necessarily better, right? So how do we actually flow the data in a way that's actionable for them, again, in this workflow? And then finally, demonstrating the value to them, right? Like, why would I actually want to engage and do this activity? So a great example, a good partner of ours is Jefferson Health System here in the greater Philly area. We started with 5 clinics, right? And what we were able to demonstrate to them is look at the value we're driving to you in terms of data and how you can action on that and getting these folks to the right resources. But also we took a lot of the burden off of them. So you know exactly what to do with a patient with depression now. You have the track, you know where to send them, you know what resources they're going to be receiving, and we automate a lot of that. So showing the value allowed us to expand from that 5. Now we're over 25 other clinics. We have NeuroFlow working in slightly different ways, right? So our women's health practice that is using it with pregnant women and new mothers, they're getting content around not just mental health support and postpartum depression as you'd expect, but like directions to the birthing center, right? Like, and all of these can be released based on their due date and triggers in the back end. And primary care, maybe now we're focusing more on diabetes and things like that. So we're actually able to customize and configure kind of this experience in order to make sure we're meeting the needs of what the providers want. So that's what we try to do, is we try to meet them where they are. And that's how we gain success and get them to adopt these new ideas is by showing them the value and why it's easy for them to use. So that's what we do every day, right?
Okay, great. How, all 3 panelists, how are we doing in terms of the long stated goal of really connecting behavioral to physical healthcare better and making the connections between and among providers and different care delivery sites? Dan, I would love to hear your perspective first and then everyone else's.
Sure. So this is not specific to telehealth. It's the general topic of how do we provide better integrated behavioral health. Yeah. So we, our agency has co-located clinicians in 14 different medical clinics. And the idea is to provide that access so that when a primary care provider is seeing someone and they say this person seems depressed or they seem anxious or they're worried, they can pull in one of our clinicians to do what is basically a consultation, and then may involve short-term work or may involve then a referral to other services. And we've also tried to include not just the clinical side, but assessing and then following up around the social determinants of health needs. So we're able to do that, but the tricky part has been about the sharing of information. So most people may know that there are specific and more restrictive requirements for individuals who come from substance use programs, referred to as regulations from 42 CFR Part 2, and that and in Massachusetts, there are specific regulations for specific licensure, in fact, for all licensures except for docs, around their ability to communicate around mental health or substance use issues without an actual release of information, as different than a consent, where release of information has to have a number of additional criteria, has to be time or event driven, where consent is more an understanding that here's what happens and there's not the same levels of restriction. So the challenge has been working within that framework and using different techniques of, not techniques, different legal options. Like there's a thing called a qualified service organization agreement that allows for substance use information to be shared between entities. So we've used some of that legal regulations in order to share information, but we still have different health records and different ways of communicating the data. So at a high level, there's the issue of the confidentiality issues and privacy issues that exist, although that hopefully will get better because of the CARES Act that was signed into law probably a year ago, and the regulations are still pending, but much of that has to do with better aligning the mental health or the HIPAA requirements with the substance use requirements. Depending on who you are, it either goes too far or not far enough, but at least it makes that more capable and also allows for consent versus actual physical release of information and allows for health information exchanges to occur. The other big challenge is that even though there are electronic interfaces and standards as part of HL7 or the CDA architecture for sharing healthcare information, not all EHRs utilize them in that way, or they always require some tweaking. And so the other thing that is happening in Massachusetts is trying to be more prescriptive around agencies and healthcare organizations actually using those HL7 interfaces so that we can share information more easily. And I think it's those things. And then going to what Matt had said of moving towards a much more automated way so that when someone does come to our system, if we have an electronic consent, that once that person is admitted, we can fire off a CCD document to the referring agency to say that, one, they're here, that these are their diagnoses, this is what we're treating them with, and that those things can happen literally in minutes versus our current model, which is we'd have to have them sign a release. We'd have to send it to their medical records. Their medical records would process it over several days, and they would put it into their EHR. And by that time, a detox client might be long gone. So I think a lot of the challenges are really what Matt is talking about is, at least in part, because we talk about a lot, is about the electronic use of data and how to much more automate those processes. And then it's the confidentiality and privacy rules being moved more towards the concepts of collaborative and coordinated care and best practices versus trying to see people in silos and not have that collaboration. And there are people who feel very strongly about the latter view and that that information should be sacrosanct and heavily protected much more than it is now.
Yeah, absolutely. And I really love the way that you did combine the process issues and, yes, the technology and the information issues. Rebecca, what are your thoughts on that? Are we coordinating better?
In our service locations and settings, in many ways, we are still in the 80s. In that we are still struggling with the coordination of care that we've struggled with these many years with primary care and behavioral health. In part, challenged by many behavioral health organizations still do not use an EHR. We do, even in our freestanding locations, but many do not. So that eliminates the opportunity really for some of that electronic sharing. But and then some of even the social determinants of health in impacting patients, not homeless patients. Think about homeless patients not having a PCP. So we're challenged, we're still very much challenged in the coordination of care with PCPs, although we continue to work like we have for these many years toward that end. What we're seeing, because we're in a post-acute care space, meaning within our organization, we have physical rehabilitation and long-term acute care and behavioral health. It's not directly toward coordinating with PCPs as much, but just an added layer of looking toward what we can do to support the behavioral health needs of those patients who are in the post-acute care space, whether they're a substance abusing patient who's in an LTAC environment because they need long-term wound care or 6 weeks of IV antibiotics, but they still need to initiate treatment, as an example, or somebody who's in, physical rehabilitation in an IRF, inpatient rehab facility, and they have understandably, behavioral health needs around whatever it is that brought them into rehabilitation.
Yeah.
So there's a whole other layer of behavioral health needs within the continuum of service.
A lot of complex patients, medically and otherwise. Yeah, thank you, Rebecca. Matt, when you look nationwide, do you see the coordination getting better? Do you see the connections, the dots being connected a little bit better now than in the recent past?
Well, definitely better. That doesn't necessarily mean good, but better for sure, right? And I think one thing that we've seen successful kind of organizations do is that behavioral health care manager, that BHC, whoever that behavioral health provider is, really has to be part of the team, right? And it has to be seen that way. They can't just be somebody that's in the clinic. They have to be somebody that's really part of the true care team. And that takes a lot of work, right? That's a big culture change. That's something that we really needed to start from implementation on to really develop. What helps with that is when we think about some of the financing for the models, right? So psychiatric collaborative care is a great example. If you're in North Carolina right now, I'm not trying to say what health plan is good and bad, but in Blue Shield, North Carolina, they are not covering psychiatric collaborative care today. So there is no incentive for us to be bringing that behavioral health care manager in a clinic to support these models in North Carolina. Conversely, up in Michigan, right? They not only are supporting it, there's no copays and deductibles for the program. So huge incentive now to bring these people into the clinic and be able to support these models. So, that's the frustration to me is we know the how, right? That part we understand. We understand how to implement these programs and the continuum that we want to move people on in behavioral health integration. But if there's not consistent funding and reimbursement opportunities or other value-based care arrangements, then we're not going to see people adopting it because we need to at least break even on these deals, right? So that's kind of my point is we know what to do to make coordination effective. The problem is getting the staff and getting that buy-in largely from the health payers in order to do it and to adopt these models. So I think what you're seeing is pockets, I guess is my point, right? Where you have the high reimbursement or at least some reimbursement, you're seeing much higher, faster adoption rates.
Well, and you've put your finger on one of the key issues in US healthcare. We get what we pay for, like literally, we get what is reimbursed. Let me ask you all, how are we now in terms of the analytics to help drive better coordination, to help drive better care management and transitions especially? Are we where we should be in that journey of 1,000 miles? And you can decide how many miles we've gone. Let me start with Dan and then go to all three of you.
Sure. So Massachusetts, as part of ACA, has implemented a system of accountable care organizations with a set of core and optional measures. And so those that affect behavioral health involve some of the things that you're talking about, Mark, which include follow-up after hospitalization within certain timeframes, assessments happening within certain timeframes, treatment plans or care plans being signed by multiple people. So in this case, it's by the member or the client, by the care manager, and even by the primary care physician. So we've come up with ways to manage that technologically. And so this involves both getting data, and critically what you're talking about is getting, and Mark used, or sorry, Matt used this phrase multiple times, actionable data. Because a lot of the systems are really set up to, we'll do this based on claims. Well, then that's 3 months later and we can't do anything with that. But how can we get data much more? And there are some systems that have been very supportive of that. And to one of Rebecca's points, you have to be fairly sophisticated. And I feel like behavioral health is still behind ambulatory and inpatient care, because our systems now, and I don't mean this in a demeaning way, are okay. They used to be substandard, now they're okay, but they still have a bifurcated system of data entry versus reporting. That's just not the same level of integration that you have in a lot of hospital-based systems.
Yeah.
But the ability to, I just got lost. Where was I?
Well, you were talking about coordinating with hospital-based systems.
Actionable.
Actionable. Yeah, that was. Thank you,
Rebecca. So the idea, so we've instituted some things in order to address that. So there is a system that hospitals, not all, but most participate in, which is essentially an ADT, or admission discharge transfer function, that goes into a database. And we have set up a process where multiple times a day we query this database with people who are clients to find out, have they been admitted or discharged from the hospital? So that way we can track them, and in our own care management systems, track, did we follow up with them within certain timeframes? And even then notifications, if it's coming close to that end of that 48-hour period, it escalates for someone else to get involved to follow up. So in those ways, we've been trying to leverage data to provide for, in this case, their HEDIS measures, but really look at continuity of care issues. And it's that kind of thing of trying to use data and having to often have parallel systems, because most of the data systems are still based on, it's a claims, it goes into a central place, which makes sense for overall reporting, but is not really actionable. And so working with our healthcare providers to figure out other ways to get that information.
Yeah, absolutely. Rebecca, where do you think we are on that data journey?
Well, we definitely are much further along than we've been in the past, I think. But we have a ways to go, and a lot of opportunity to implement actionable data. To my colleagues' points, within our organization, what we focus on with just with KPIs, and building reporting of the KPIs into our electronic health record, that's clearly a step forward than, being on a paper chart, collecting things manually, and being able to use that data to take action to improve your outcomes for your patients. And then the other piece that we've been exploring, and I'm really excited about, is the use of AI technology with the data feedback loop, in terms of knowing who's accessing, who's but this is for post-discharge follow-up. So being able to utilize that technology, not only to reach out to people at discharge, but to have data available about the demographics of who's using the technology, what their needs are, but also having that higher level capability down the road to intervene prior to decompensation. So if you have the patient engaged in the technology, and they're responding to those, outreaches, but they answer in a certain way that tells you they're beginning to decompensate, or they have barriers to accessing medication or whatever it is, such that would lead them to decompensation, that you have that feedback and the capacity to then outreach with a live human being to try to assist them. So, those are, I think, features that, we certainly didn't have 5 years ago, 10 years ago.
Absolutely. Matt, where are we on that journey towards really having the data be fluid and totally meaningful and useful and connective?
Getting there. We're definitely getting there. The phone in your pocket helps a lot, right? So 2 ways, because first we can think about patient-reported outcomes, right? How is somebody feeling? Let's ask them, right? And if we can do that in an engaging way, we can get that information in real time back to us, right? So why, to your point, like claims analysis, I'm not going to know about that for months, years later. So being able to really do patient-reported outcomes, and what's great about that too is then you can actually target resources in real time. So Rebecca, you touched on some social determinants, right? When we assess for food insecurity, if we identify someone has food insecurity, we can immediately target them with the resources in their area for what to do about food insecurity. So not only can you use that as the provider, but now actually able to use the technology to actually provide the intervention as well, right? And then the other side of it is more passive data collection. So thinking about, whether it's biomarkers and a lot of other cool things we can use, but really kind of being able to use kind of the activity level, thinking about someone like cocaine use disorder or major depression when step counts are all out of whack all of a sudden. So there's a bunch of this cool passive data that we're able to use to at least identify that folks need a second look. Right? We're not saying like, hey, this person is in crisis, you need to call them right now. It's like, this person is escalating, right? And we need to reach out earlier to prevent those, ED admissions and utilizations. And we're getting really close to being able to do this in near real time now. The problem is, how do you keep patients willing to give that data, share that data, right? Helping them understand the purpose of it, which is the challenge, right? And then also, if you think about my chart and some of these other apps and engagement, people don't go in and click their PHQ-9 in my chart. The engagement rate is something like below 1%, right? So how do we incentivize patients to be part of their care? We do that with behavioral economics, points, you get gift cards, things like that, right? How do we actually make this fun and patients want to be a part of that experience of sharing data? So I think we need to really explore that more with our friends in the consumer world to really understand what that means and how to be able to do that.
I don't want to fall into a total rabbit hole, but very briefly, do you all think that we'll be able to fix some of the regulatory issues that still hamper us from appropriately sharing behavioral data? And you all know which regulations I'm referring to. And I do want to keep it brief because we only have a few minutes to discuss this, but I just wanted to see whether you had any opinions, any of you. Rebecca, I think you do.
Well, I was going to say I'm hopeful. I'm hopeful that, with action among our, our professional organizations and even individually as we speak with our, our own senators, representatives, and so on, that we can move that needle forward.
Okay. And Dan, what do you think?
I'm also hopeful because of both the CARES Act, which, again, as I mentioned, aligns with the various regulations to make information sharing more efficient and less ambiguous. And then also the Cures Act, which specifies the way in which different healthcare organizations share information with specific HL7 interfaces and protocols. I think that standardization will help. We're definitely headed in that direction, in part because there's an understanding that the collaboration of different professionals, and I think Rebecca started with this, the importance of behavioral health, and actually, and Matt did as well, the importance of medical and behavioral health to work together is so critical for outcomes, and that the things that impinge on that or hinder that are not positive. And I think that's part of our message to clients when they say, well, I want my information segregated. I only want so-and-so to know this and that. And part of our refrain, and not everyone agrees with this in the organization, is to say, we are not serving you well by doing that. We actually put you at risk by not sharing the fact that if you're starting to use substances and your psychiatrist doesn't know, you could have a really negative outcome. And we don't want to participate in something that could hurt you. So we really want to be able to share information on your benefit with all of the HIPAA guarantees. And so I do feel like there's an acceptance, slow, because people are very protective of their information for lots of good reasons. But on the other hand, it's trying to provide good integrated care.
Yeah, absolutely. Okay, we have literally just enough time for me to ask each of you to kind of make a concluding statement. And I'm going to ask you to either give us a prediction for how things will evolve forward in the next few years, or a piece of advice, or if you can talk really fast, both. So Matt, you go ahead, and then I'll go to Dan and Rebecca.
Sure. What's coming is, your mental health treatment is going to be available to you in primary care, right? That's coming. And whether you have mild or moderate condition, that's where it should be treated, because we have a gap and bandwidth gap here, and we need Dan and Rebecca to focus on those higher acuity individuals. And then in terms of my advice, keep an eye out for what's coming down the pike. There are all kinds of cool reimbursement opportunities coming down. So even if you're in value-based arrangements, that there's value there as well. But in particular, some of these RTM codes, now that they apply to psychologists, are going to be a huge opportunity for y'all if you're on the call. So keep an eye out for ways you can use technology to not just improve your practice, but also potentially have some ROI as well.
Wonderful. Dan?
I really love Matt's aspirational view, and I think that is the way to go. And that the key parts, and Mark, you and Matt both spoke to this, is the reimbursement has to happen. And so every time we try to do something that falls outside of a model where you have an assessment, you have a treatment plan, you see people for a long period, they say, well, what is this? Because even the idea of just seeing people without an assessment, that you're going to, like in the primary care model that we're talking about, the doc brings in a social worker to meet with a family around an issue. Well, we have to do an assessment. They may not come back for ongoing work. You've got a one-shot deal. And so some of the insurance companies have been willing to try out this new service, but it's still an anomaly. And I think it's trying to view back to an old social work model of start where the client is at, because we have these projects and these paradigms that don't fit where most people are, which is most people get 1 or 3 sessions, and then I think on average 10 is the most that most people get. So let's have a model that reflects that, whether by telehealth or direct. And to Rebecca's point, I think many people in our field are moving that way, but there's institutions, because of their sense of history and loyalty to those traditional models, are hesitant to give it up.
Right. Yeah, very well said. Thank you. Rebecca, your thoughts. I bet you can do both predictions and advice in 2 minutes.
Did you see my crystal ball in the background? My advice, I think, to all of us, and just generally, is, at the heart of why people don't seek behavioral health services, or why we're siloed, and why people want their data discrete from physical and mental health, has to do with stigma. So I think, no matter where we are and what we're focused on within behavioral health, and even in our personal lives, that we continue to openly talk about mental health and make it be as okay to talk about our mental health concerns as we might talk about, our physical health concerns. So I think that's the first thing, is just to stay focused on overcoming the stigma. We're making some progress there. Very tiny, but we're making it, and I think that's, an important point. And then, prediction, we will continue to advance. We've already made, and the pandemic has not been a good thing. It has not. But for talk about mental health and focus on mental health, it has helped us advance forward. I think to Dan's point about parity, that we need regulations, and we need parity around mental health, substance abuse services, and we need for these technologies that allow more people to have access appropriately so, meaning those who are not in crisis where they really do need to be in an emergency department or an inpatient unit or so on, that those services become within the norm of our delivery system, and that our payers see those as valuable to their members, and realizing that yes, there is a cost driver there, but there is also a cost driver that's a benefit, meaning if people seek these services earlier on and there's less stigma, then just like with physical health, if we take care of our diabetes early on and do the right thing with our diet and so on, the cost to our system, our healthcare system, is going to be less in the long run. So I think just advocating for preventive health across the board, including preventive mental health.
Yeah, well, I absolutely agree with everything. I will make one kind of editorial comment, because I'm an editor. We can't help ourselves. I agree completely with you, Rebecca, about stigma. There also has always been concern about discrimination from employers, insurers, et cetera. And as we reduce the stigma, the fear of discrimination also starts to go away. And I think it will, in the younger generations, go away a lot faster, right? So that's a good thing. And I agree with everything all three of you have said. I think what the irony of the complexity of the pandemic has been, on the one hand, it's created a terrible mental health crisis in this country and globally, and we all know that. But on the other hand, it's also opened up these discussions much better, and it's made policymakers far more aware that we need adequate and equitable reimbursement systems for behavioral health care, just as for physical health care, right? This is how we move forward. So I think there has been greater awareness because there's been such a mental health crisis globally. I mean, they're doing surveys that find, people in Malaysia are depressed, right? It's not just the United States. So hopefully everything will move forward. I do think that the level of awareness is greater. And I will also say that I think that the value-based contracting is going to end up being good for mental health, for behavioral health, because as things become more integrated, there will be less of that historic resistance to really adequately reimbursing for this vital form of care that's as important as physical health care. I hope that makes sense to you. So thank you all very much. This has been absolutely fabulous. We've basically run out of time, but I want to thank you all for your expertise and your wisdom and your willingness to participate here. I know I've learned a lot, and I know our audience has. So Dan, Matt, Rebecca, thank you so much. It's been a wonderful panel. And I know that Matt, thank you. And Matt Rayner, our publisher, is here to conclude the session. Thank you again, all of you. You've been fabulous.
Thank you, everyone.
Yes, thank you, Mark, and thank you, panelists. And really another big thank you to all of our faculty and partners that were a part of today's Population Health Virtual Day. We will be concluding the 2021 Digital Health Virtual Series on December the 16th with a virtual day covering IT infrastructure, governance, and building the service desk of the future. If you are not already registered for that program, make sure you go to our website at hcinnovationgroup.com and register today. We hope you all can join us at that virtual event, which will be concluding the 2021 Digital Health Virtual Series. Until then, we hope you have a great night. Continue to stay safe and take care. Thank you very much.
Thanks, everybody.